if she had received imaging earlier on, this could have been caught at an earlier stage, and stage 1 cancer is curative.
Right.
She'd be here today.
Welcome to a new evolution in the treatment of serious diseases and technologies for the extension of lifespan. Join Dr. Robert Hariri, co-author of New York Times bestseller, Life Force, on an exploration of the medical breakthroughs that are changing health as we know it. This is Piloting Health.
Hi, everybody. This is Dr. Bob Hariri from Piloting Health. And today I'm very excited because I have with me today not only a close personal friend and colleague, a buddy of mine that I admire tremendously, a shipmate, a guy that has done some amazing things in his professional career as an emergency medicine expert, as a former Navy captain, running the chief medical officer in Navy Medicine East, also the chief medical officer at Robert Wood Johnson Barnabas Health and the Clarimass Medical Center, and someone who has shared with me a passion for advancing healthcare by looking at ways to preempt disease and address the needs of preservation of human performance, health and wellness. And we're both on a mission to combine our passion and our expertise to drive this field forward. So, Dr. Frank DeSantos, welcome aboard.
Thank you, Bob. What a tremendous honor and privilege to be here today.
So for all you out there, you guys know that I'm a neurosurgeon who really spent my academic medical career focused in traumatic brain injury and spinal cord injury. Frank's expertise spans the range of emergency medicine. So everything from trauma to infectious disease to acute cardiac crisis, et cetera. So his expertise really is he's the know-it-all, can take care of all of it kind of doctor. But most importantly, coming out of the Navy, where the responsibilities are to take care of enlisted and personnel and officers and their dependents, but also creating an environment that optimizes health of the most high performance people in our society. You know, our warriors out there are obviously critically important to the safety and security of our nation, but they have their own needs as well. They've got their own personal and physical needs, and health and wellness is now an increasingly important topic in the military, in large part because of professionals like Frank. So, Frank, give us all just a little bit of your background, because you know, I know and love you as a brother, but for me, I've always really admired how you transited from military medicine into community medicine.
Well, Bob, thank you for that. I tell you, having been lucky enough to have worn the sacred cloth of our nation, the uniform, and served our sailors, what was a tremendous honor and privilege. And I was fortunate to have done it for 20 some years. And during that time period, I had the privilege of serving in multiple duty stations and treating different targets of the Navy. So I was a flight surgeon for some time period. And interestingly, I got to be a flight surgeon in Italy. So I got the fortunate duty to go to Sigonella, Italy, where I stayed for 3 years. I got to treat pilots while I was out there, and also their dependents and our Navy sailors that were stationed in Sicily during that time period. I got to bounce around all the different Navy bases in Europe, which was a tremendous time with a group called MedX. I got called up to serve very arduous duty, I will say, in Greece for 6 months when the Navy flight surgeon there got ill and had to be removed. I stayed there for 6 months, and much of the duties associated with being a flight surgeon in that time period of my career was preventative. It was really preventative measures, keeping our pilots as healthy and in an optimal condition to be high performers in the aircraft, and whether it's high performing aircrafts with our jet fighters to our helo guys, and being with the air crew that supported them as well. You know, we took a lot of measures, whether it's exercising and nutrition, making sure we took the right amount of sleep before missions. It was really great. I transitioned from that to San Diego, California, where I did training in emergency medicine at UCSD and Naval Medical Center, San Diego. I got to be there for 4 years. During that time period, I learned the skills associated with emergency medicine. And when I graduated, an opportunity presented itself to go back to Italy, and I jumped on it. I went back to Italy to Naples this time, where I was an emergency doctor for 3 years in emergency medicine.
Phenomenal, phenomenal. I mean, and for those of us who kind of understand the military medicine system, it's a incredibly challenging environment because, as you pointed out, these appear to be, young, healthy, active people, but they are putting their bodies and their health to the test, right? The environments that they work in, the physical and emotional and psychological challenges of being in that environment is incredibly hard. So your expertise spans all of that, which has always really, really impressed me. Now in your role as chief medical officer at a major healthcare system, one of the largest in the country, how have you used your skill set from the military to become really a world-class healthcare executive?
Well, the transition from the military to civilian is not as smooth as one would think. And in the military healthcare system, there's not such a thing as private groups of doctors or private medical groups. There's all one. It's all one healthcare system. We're all TRICARE. We're all Department of Defense related. So coming to the civilian sector was very interesting to see these target populations. And what's most interesting about that is, depending upon a person's access, depending upon their payer source, you'll see presentation of diseases in different stages. You'll see folks with cancers in more advanced stages, depending upon their access to care, depending upon their insurance. So I find that to be the most fascinating transition from military healthcare system to civilian, because in the military healthcare system, we all have access, and we all have TRICARE, one form of it or another. So there's no barrier related to access in the military healthcare system that in the civilian population you'll see. And I think that's probably the biggest challenge. One of the biggest opportunities is getting that access and earlier diagnoses that you see in the military healthcare system.
It's interesting because of that, you're pointing out some really important elements to how your career has shaped your vision of the future, which is that we got to start addressing these healthcare problems in a very, very proactive, preemptive way. And you and I share often in the aviation world, it's all about doing intensive root cause analysis every time you identify a problem, so that you can create strategies that will preempt that problem in the next setting. You and I both want to do that for patients, essentially create almost the equivalent of an inspection and critical component replacement strategy, so that before people develop symptoms and irreversible disease, we intervene. So that's one thing you and I share, I think, common objective around.
Yeah, absolutely. And Bob, you've lived it. While I was in the military, every 6 months you have to do your PRT.
Right.
While I was there, I did.
Explain that to everybody.
Well, if folks aren't familiar with the PRT, it's a physical readiness test. And the physical readiness test is something every 6 months. You stand on the scale, they measure your body fat, they see what your weight is on the scale. And then on top of that, they see what your performance is. How many sit-ups can you do? How far can you run? How many pull-ups and et cetera? Some people like to swim. So there's a measurement of performance associated with body fat and how much do you weigh every 6 months. And while I was in the military, I'll tell you, I didn't always enjoy it. I passed it every time, thankfully. If you don't pass it, there's consequences related to not passing the PRT, but I did pass it. Leaving the military and coming back onto civilian life, that's probably the number one thing I miss, is that preventative measures with the PRT.
It's interesting because, for those of us in our audience who are kind of getting their first introduction to discussions about what military medicine's like, I can tell you, Frank, you're a buddy of mine. You're an athlete. You've always been an athlete. You look like a linebacker. You still can kick everybody's butt.
Defensive guard. I was a defensive guard.
A guard. But that's typically not a lot of our colleagues in military medicine don't necessarily look that way, But it is important. But it also you create a role model. You're a role model for other enlisted personnel, officers, and so on. And that's one of the things that I think you bring to the table that a lot of others do not. So let me switch gears a little bit and start talking about what you and I have really passionate about now, which is what we do at Cellularity, what we do at Fountain Life, and you and I both recognize that the time has come for new tool sets to be made available to physicians that can actually address the acquired and accumulated degenerative processes that limit our health as we age. You and I are both passionate about regenerative medicine, cell therapy, all the allied tools that are available. And so, in your current sort of community medicine, chief medical officer leadership in the healthcare system, what are the diseases that you see as really burdening the healthcare system that we can address with some of these regenerative medicine strategies?
Yeah, without question, there's tremendous opportunity that's out there. In being in the world of sick and reactive medicine, which is where I find myself day in and day out, you look across the spectrum and you say, geez, some of the sick and reactiveness didn't need to occur. It really, truly didn't need to occur. And I think there's various different aspects of that out there that are opportunities, one of which is often referred to as the silent killers, hypertension. And my understanding of hypertension has greatly changed as I now developed an understanding of regenerative medicine. The understanding that inflammatory conditions in the body, particularly in the endothelium, can lead to hypertension. I mean, that's one thing where your food is medicine. That's one thing where the microbiome in your gut is extremely important to maintain that inflammatory condition at a lower state, so you don't get, like, for example, hypertension. It goes from something simple like that, where you're watching your diet, you're keeping your cortisol levels low, keeping the inflammatory processes low, to something more advanced that I've seen here at Cellularity that you guys are doing with some of these matrix materials like Biovance, where at our facility we have a very large wound center, and a very challenging condition are folks that have non-healing wounds. And these non-healing wounds occur for various different reasons, of which a common is diabetes. Vascular disorders and diabetes lead to these non-healing wounds. And truthfully, it's a tremendous, tremendous problem. I mean, the out-of-pocket cost for a family with a stage 3, stage 4 wound is somewhere around the area of $40,000. The copayment associated with that. And then never mind the hassle of coming in and out of debridements, coming to the hospitals for that. So if there is a way to treat, a modality of treatment that would decrease the in and out of coming to the hospitals, decrease those out-of-pocket costs, promote the healing, that would be remarkable. I think that would be very much life-changing. So it goes from the simple of let's eat good food, keep the inflammatory conditions down, keep the micro in our gut healthy, to the more advanced with these matrix products of let's keep these wounds in a more regenerative state, healing, to keep folks out of the hospitals.
I couldn't agree with you more. And you're hitting the nail on the head, seeing it from the vantage point of an executive who has to manage a healthcare system. We're talking about chronic wounds and the consequences of diabetes, where people develop these non-healing wounds that are, not only are they very difficult and expensive to manage, they're a source of tremendous disability. They're painful. They lead to infections, which in some cases can become life-threatening. They are one of the factors which diminish quality of life in the aging population who are dealing with diabetes. But it's going to increase because the number of people with metabolic syndrome, the number of people with just insulin insensitivity, it's an unfortunate consequence of life in modern society. That being said, as surgeons and as doctors who have to deal with these patients, we need to find better tools. And so you and I both recognize the value of some of the regenerative medicine approaches. Some of these things include the biomaterials that can serve to stimulate and encourage wound repair. There's, as you know, at Cellularity, we actually have conducted clinical trials using stem cells to stimulate two things: improve vascularization, improve blood supply to the extremity that's got a wound, but also to stimulate the regenerative process. In your professional life, where do you see the greatest potential excitement in the wound management community? These are wound surgeons, internal medicine doctors taking care of these patients. Where do you see the excitement?
Well, Bob, not too long ago, we embarked on a strategy to decrease wounds throughout the hospital. And what we found is, as you go into this realm of wounds, there's much collateral damage associated with this. So let me get my point on this. Our case management department, when they work with a patient that has a diabetic foot wound that's non-healing, or a pressure injury that's not healing, there's a family member that needs to transport that patient to the wound clinic to their doctor 3 times a week. Every day when it's intense. Sometimes multiple times. Excuse me, not multiple times a day, but sometimes it's twice a day, once a day, multiple times a week. So there's a lot of transport going back and forth to the hospital. My point being,
It's a logistics challenge.
it's a logistics challenge, these wounds. So there's the wound itself to the patient, and then the collateral damage to the family of having to bring these people into the wound clinic. And guess what? The treatments are helpful. We can treat them, but we can't really heal them. And these later stage wounds are non-healing, and it's a lot of wet to dry dressings. It's a lot of wound vacs to these things. And the average cost to a family, we did a process improvement project that came from the AHRQ, and they estimated $40,000 was the out-of-pocket cost for a family for these non-healing wounds, of going back and forth to doctors, time lost from going to work for the caretakers. Right. If there's a product that's out there that can regenerate the skin, regenerate healing, and allow these wounds to heal in a way that it's much improved upon our current system, it would not only for the patient benefit, but the benefit to the families, to the caregivers. I mean, all these out-of-pocket costs and the collateralness associated with this would be drastically improved. I mean, we have folks that we can't transition out of the hospital because we can't get them to the wound clinic.
Yeah, yeah. And Frank, you may know, I may have shared this with you. My mom, her demise began when I first noticed as a young surgeon. I was visiting, and I noticed that she had an ulcer on the lower aspect of her left foot, and she kind of hid this from me. And I saw it, and I said, "What's this?" And I went and immediately brought her in to start the process of treatment. But and this goes back into the 80s and early 90s, when the best tools we had were debridement, like you said, antibiotics, and dressings. We didn't have any regenerative therapies.
Wet to dry dressings.
Wet to dry dressings. Yeah. And remember, we used to joke about it. Unfortunately, in gallows humor, we used to say, well, these patients suffer from salami syndrome because you just keep slicing away. Yeah. I mean, horrible as it sounds, having to continually surgically attempt to minimize the exposure of the wound. The natural history is these wounds always get infected, right? And then you get these ascending infections that can become the source of sepsis. The only tool we used to have was amputation.
Right. We have patients right now, and one case that comes to mind, a patient that has a wound that's non-healing, and it's beyond the patient's ability to manage the wound, and the family can't take the patient in and out of the wound clinic. So we're having to transition this person to a subacute facility just because of the wound.
Yeah.
And these non-healing wounds are so burdensome to the patient. They're burdensome to the families, to the system. It's a major, major problem. And again, it's not all these wounds are diabetes. I mean, pressure-related wounds and vascular burns and trauma. I mean,
people who smokers develop peripheral artery disease,
right.
And they destroy their small supply blood vessels, and they get basically what are really ischemic tissues. The tissues don't get enough blood supply. They become necrotic, and just like a diabetic ulcer, it's a progressive, irreversible phenomenon.
Right. Yeah, no, exactly. It's very exciting to know that a future state is going to have some modality of treatment that's going to prevent some of these challenges that the families and the patients are going through. And because it's much needed. And I think our current regimen that's out there is good, not great. And the challenges associated with these non-healing wounds are tremendous for patients and for families.
So why I'm excited is that I look at the approach we're going to have to take going forward, that the regenerative medicine approach, whether it's cellular or biomaterial or sort of the structural biomaterials, those two are going to work in concert. And so if you think about it, as we're going to get better and better at managing things like diabetes, peripheral artery disease, having the tools to stop the progress of the wound and help it remodel, that's going to be, I think, a requisite pathway forward to address these problems. So you and I think, agree on that.
Yeah, I remember us relating it to the Navy. I remember the P-3s were the old subplanes, and I remember when I was in the Navy, early part of 2000s, I was in the P-3s at Sigonella, and to apply it to the wounds, we would patch these things together.
Exactly.
I mean, literally, there would be patches on the airframe. You'd be like, oh my God, when was this plane built? 1950s. But now the P-3s are brand new. They're beautiful. They're
changed the whole platform.
They're not turboprops any longer.
That's
They're
right.
jets.
Right.
And so much like I think like the wounds, right? I mean,
that's a good point.
We're patching them and keeping it together, but regenerated new aircraft with jets on it. And there's nothing better.
It's a very, very good point. And for those who don't know these P-3s, these are the surveillance aircraft that are principal job is to protect us from enemy submarines,
anti-subs.
Anti-subs, exactly.
Yeah.
And they're the characteristic boom coming out of the tail. You can't miss them. So now let's switch gears a little bit, because I think you and I both recognize that regenerative therapy is here to stay. It's going to change the way we manage diseases. But let's talk about how, for us, where preservation of performance is a mandate, you've got a real passion about delivering wellness tools to the general population. Tell us about your interests and efforts there.
Well, that really originated back roughly about 9 years ago. My late wife got diagnosed with stage 4 cancer, and she was an athlete. She worked out. She ate organic food. She never smoked a cigarette. She didn't touch a drink. She actually studied at NYU French literature, and she was, very much into health. What we thought at the time, she was doing everything right. And I would still say she did, but she came to me one time, Bob, saying she had pain on the side of her chest, not knowing what it was, and she kept complaining about it. She ran a 5K. At the end of the 5K, she had a tremendous amount of pain, and she beat me, by the way, on the 5K. She came to the emergency department one day while I was working, and while I was in the ED with a friend of mine, she shot a chest X-ray, and it was a life-changing moment. We're like, oh my God, what's going on there? And from that moment on, it was a series of 13 months of doing all that we could. And unfortunately, the cancer got progressive, and we had hospice at home at the late stages of it. But I learned from that journey that as good as medicine is, and as much preventative things we can do, things can come up. They can come up. And being on the cutting edge of looking at the imaging of her body, if she had received imaging earlier on, this could have been caught in an earlier stage. And stage 1 cancer is curative.
Right.
She'd be here today.
Right.
And the effects with my children and myself would have been tremendously different. It would have been a different course of life. So that taught me how important it is to really kind of approach disease in a fashion and in a model that is much more from a standpoint of being preventative, of finding earlier stages, for example, of cancer, and looking at other elements and ailments for treatment. Being an emergency doctor, I see disease in the late stages. I see crisis.
And in the acute setting.
I see it in the acute setting. And being a healthcare executive in acute care hospital, it's the same thing. And I often find myself thinking, what if this person had done things differently? what if we had interceded earlier on with small changes, kind of like the book Atomic Habits.
Yeah.
If we had just taken those small little habits and done things differently, it literally would change the course of their life. It would literally change the course of their families and their children. And so I learned a tremendous amount from that. And I've come from that experience with a much more open mindset about preventative and regenerative medicine.
It's interesting. I mean, your personal journey, which, I feel for you so much, because being a doc and having a family member who you're doing everything right, she's doing everything right, and you were beyond the opportunity to detect something early. It is the most difficult situation to be in, and you and I have talked about this a lot. Now it's a mission. We have to find ways to give people opportunities to use the tools that are at our disposal to identify things early enough so that the clinical efforts that are going to be made will be curative. So you pointed out something really important. We've known for a long time. Everybody's afraid of two things that are causes of premature death: cancer and cardiovascular disease. Today, with high resolution imaging supported by breakthrough data tools like AI and machine learning, we can in a cost-effective way screen people early, identify lesions before they're symptomatic, just like in your wife's condition. The spot where her tumor was in a tissue that doesn't have those nerve endings like you used to point out to me. So she was living without the warning, the warning light to tell her, I got to look more closely. It wasn't until it expanded and affected that nervous tissue in the lining of the chest wall that she actually had any pain. And by the way, because she was an athlete and everything else, she was probably very stoic, so, I can run through this. I can do another 5 miles tomorrow, etc. And, so you and I both recognize it's imperative. It's imperative to make available to people these tools. So you and I are passionate about using the types of resources available at groups like Fountain Life to make available high resolution imaging technology, the highest resolution molecular analytics that include things like genomic testing, biomarker testing, and so on and so forth, and then continually applying modern sensors and so on to monitor not just in a snapshot when you're in the doctor's office, but continually monitor things like blood pressure, monitor things like heart rate, electrocardiographic activity, all these things which can signal early when things are going awry. And it's very tough in the conventional medical system where a patient sees his doctor once every 6 months, once every year, to actually be there at the right time to detect a problem early enough to intervene. But if you're proactive about it and you incorporate all these systems, you can get in there early enough to make a difference.
Yeah, I can tell you, you remind me of a friend of mine, Chris Straff, the linebacker in the NFL. He and I became really good friends because his wife had the same cancer my wife did. And his wife died shortly after getting the diagnosis. And she was a cheerleader in the NFL. He was a linebacker for 9 years, played on several teams. He started a project, Bob, called the White Ribbon Project. We have the pink ribbon for breast cancer.
Right.
He's now started the White Ribbon Project for lung cancer. And his emphasis is exactly what you just stated. It's the early detection, early diagnosis. The American Cancer Society now has the low-dose CT scanning imaging for folks that are at high risk for lung cancer. But the fact of the matter is, and Chris is out there doing the best that he can, being an advocate for this, we don't know, particularly with the cancers that my wife got, that his wife got, we don't know all those risk factors. So how important it is to be proactive and to step ahead of this. As opposed to being reactive. We've learned the hard lessons, my family and his family, on reactive medicine and reacting to the symptoms as opposed to being proactive. And so he's out there promoting the White Ribbon Project, promoting early detection for those patients that do meet the criteria by the American Cancer Society, the Thoracic Society for low-dose CT imaging. He's out there doing the best he can. There are different various grants from the Department of Health that allow for people who meet that criteria to get those scans. But really, I mean, we're all at risk. Like Mr. T recently, got lymphoma, and his famous comment when he got that, they asked him, what his experience was like, in which thankfully he's doing well with it. But he said, folks either have cancer or they're scared that they're going to get cancer. And no doubt, if you're proactive, you can really get on top of this thing and fight it and be curative.